All right, ladies. Y'all doing all right?
Yeah.
Okay, good deal. So again, I'm Josh with TrvStar Strength and Rehab, physical therapist, strength coach, and you ladies are.
I'm Melanie Abbott,
Yep.
physical therapist, pelvic health physical therapist with Empassion Pelvic Health.
Okay,
Go.
cool.
And I'm Noelle Eads. I'm her partner, also pelvic or physical therapist, and we co-own Empassion.
Okay, good deal. So where y'all located?
We're located downtown Johnson City, 207
Okay.
North Boone Street.
Nice,
Kind
nice
of in
little
the
plug there.
library,
Right?
yeah.
Okay, cool. How long y'all been there?
6 months. Yeah, August. Yeah.
Okay, so it's still pretty new for you, huh?
Yep.
Okay, yeah, that's definitely. So we're at TrvFit, obviously. Y'all walked in, but for people that are listening and watching, we're in TrvFit, so we're in a gym. So if y'all hear barbells like banging and clashing, we do apologize, but it should be good. As long as somebody's doing like wall balls right outside. So, but yeah. So tell us a little bit about Empassion and kind of what got y'all started, all that kind of stuff.
You want me to go? Sure. Yeah. So Melanie and I graduated from ETSU together 9 years ago. So we were classmates.
Cool.
And we specialized in pelvic floor rehab immediately out of school with a big corporate company. And at the time, it was really great. We received like a lot of continuing education, a lot of manual therapy, ortho pelvic rehab kind of stuff. I got a lot of knowledge, but the clinical environment just became kind of a struggle, just really high volume, really focused on numbers, productivity, get patients in, out, and especially in pelvic health, that's just really challenging.
Oh my gosh, I can imagine.
In terms of just delivering high quality care to patients and really being able, I mean, it's a very intimate thing, a very intimate condition. We treat urinary bowel sexual dysfunction and just trying to treat these patients in an environment where there wasn't a lot of privacy, a lot of one-on-one time, just was really, it became to a level that we just felt like it just wasn't the place for us anymore. And so we moved on and so we ended up contracting with a chiropractor and started a practice there. It was still fairly high volume, more so because of demand, but then also we did at that time take insurance, and then reimbursements really affected our productivity in terms of, we really had to see at least 2 an hour to be sustainable. Just when you're small and private, that's just kind of the way things are. So it was a little slower, but still pretty busy. At some weeks I was seeing 75 patients a week, that kind of thing.
I just want to throw up just thinking
about that. It was a lot. And it was also busy because the demand for it was growing, which was exciting, but it was just trying to find that balance of quality care and meeting that demand, and then also dealing with a lot of restrictions with insurance. At that time, pelvic health was still not super well known, I would say. It's been around for a long time, but really, I would say over the last 5 years, it's really taken off. But before that, especially with dealing with insurance, they're like, oh, that's not musculoskeletal. Like, we're not going to reimburse you for that. Or like, oh, we'll give you 3 visits to treat this like chronic pain issue. And it was just a lot of frustration.
Yeah.
But we did what we did. And, at that point, we really didn't feel like we could go another route in terms of insurance. We felt like at that point, we really just still needed to take it, to try to meet the need.
And also because pelvic health wasn't very well known.
Yes.
So it's hard to go into a different model.
Yeah, because a lot of people are like, what the heck is that?
Mm-hmm. Right.
And so we were there for a little bit, and then an OBGYN office approached us to start an in-house program for them. And, that idea of collaboration was really exciting, to work with those providers. And so we took our model over there and just kind of still dealt with the same stuff, just overproductivity, just, a lot of concern about finances, insurance reimbursements. That just really frustrated us and felt like we were limited in what we could do. It just added a lot of stress because we really wanted to give the best care we could. And so we oftentimes would really burn ourselves out trying to be high volume, but also deliver good care.
Yeah.
And so we were there. And so that was, about 8 years in, I guess, 7, 8 years in at this point. So 3 different,
we started there in 2018.
Yeah. So 3 different environments we attempted, and just kept running into the same issues. And so we were finally just, me personally. So Melanie was able to kind of take a step back part-time. Well, really needed to take a step back to part-time with where she was in her life as a mom of 4.
Bless your heart. I have one, and it's insane. So I can imagine.
I'm like really happy when I feed my cats.
Yeah. There you
That's
go.
where I'm at with life.
Gotcha.
But for me, the burnout was really, 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 really high. And my mental health and physical health wasn't great. So we kind of were just like, you know what, it's time to just do it ourselves.
Yeah.
And so we started planning and dreaming. We've been dreaming for a while, but really,
I mean, we were dreaming back before we even joined the doctor's office,
Okay.
but didn't feel like it was the right time for the market.
Yeah.
And so it was kind of like, this is kind of where we want to take this because we feel like this would offer the best care and be able to give us kind of the treatment options that we wanted to do, but that we weren't sure that the market was really ready for that or that people really knew about it. So just kind of waiting on the timing until we were ready kind of in places in our life to do it.
Yeah.
And I think direct access laws changing in Tennessee was a big game changer for us too. Like prior to 2020, I don't think that we would have been able to be successful. And so, with the improvements in direct access, being able to see patients for longer and make it less restrictive on care. And so we started kind of planning and dreaming last year, and things moved really quickly.
Yeah, way faster than we expected, but
that's a good thing.
Sometimes it just happens that way. You have to run with it.
Yep, for sure. Well, and that's what, talking about direct access, for those that don't know, that's just where you don't need a doctor's order. So with that, I mean, as far as us being in the gym, that's something where if somebody gets injured out here, they come right over here and have us check them out. You know what I mean? So that's the beauty of it. So I'm curious, because like as far as direct access goes, like, because you all have been without direct access. So that was like, you think that was one of the catalysts that kind of made everything pop off for you?
I mean, definitely it made it so that we didn't have to always be going back and forth between doctors.
Yeah.
So that was a big thing. But also I think that the people were paying out of pocket because of what they pay for high deductible insurance more than what they pay for us. So when we started seeing that was another big thing.
Yeah.
And we're like, okay, I think that actually we can offer better.
Yeah.
Better cost, better service, better everything. So
So
that
are
was
y'all
a big
100% cash?
So we do out-of-network benefits.
Okay.
So we will give the patient a super bill, and then
Gotcha.
they can submit it to your insurance. But we're out-of-network for all insurances, including Medicare and Medicaid.
Okay.
So we cannot see Medicare and Medicaid.
Yeah. I hope that changes.
I know. I wish it would.
That's
Talk
insane.
to the government about that.
Yeah, for
because
real.
we're happy to see them, but it's Medicare for us. So.
I'm sure that's hard too. Get people coming in.
There's a big population for that in pelvic health, and it limits our ability to help kind of the older population, and it restricts some things in terms of like TennCare and Medicaid. And we have a lot of patients that would self-pay, but they're just literally not allowed to because of the government.
So
and it's a frustration, but it's also the limits that they put on our care, especially in pelvic health. Like it is just not. It's unfortunately for us not worth that cost.
Yeah.
Both from what the restriction is in terms of like things like reimbursement, sure, but also just like how often we can see patients, what we do during treatment, things like that,
what type of equipment we have in our gym, things like that.
Yeah. And in the pelvic health world, it's like to be told by an insurance company who has no idea what we do. Like,
no degree.
Especially, with the specialty where it's like they don't even know that there is a pelvic floor down there. And so it is an unfortunate thing, and we do very much hope it changes. But one of the things we're trying to do to kind of counteract that, we're really trying to do a lot of community education. So we started a social media. So we have an Instagram and a Facebook, and we try to post educational content. We do monthly workshops with outreach and education, stuff like that. And just in hopes that people will also see that stuff and learn some things they can apply, stuff like that. And hope that someday things will change a little bit there.
Right.
Yeah. Well, and as far as workshops go, like we kind of do those as well. That's something we've talked about collaborating one day. So, definitely be on the lookout for that, because that's something we try to, want to, mesh, I guess, the lifting crowd with pelvic floor. Because, I mean, that's huge. Like,
absolutely.
I could only imagine. Like, again, I'm a rookie when it comes to pelvic floor, stuff. So, I guess thinking about the insurance versus, non-insurance side or cash-based, what would you all say, like, if you walk me through the, I guess the full session from before, whenever y'all were having to deal with insurances, how did it look different than now? I know that's like a loaded question, but like if you could, walk through a general, from eval when they walk in type thing, before versus what it is now. You just do highlights. It has to be like,
I mean, I think the big thing is, with insurance, you're looking at units, you're looking at variety of units. So that kind of, and depending on if it's Medicare or what type of units they will accept. So sometimes you change your plan of care or the way you're going to treat based on what insurance requires.
Yep.
So I think that's a big driver.
Yeah. And then, if reimbursements are at a certain rate, then having to see more people in an hour. So in our sessions, we do hour one-on-one.
Yep.
And we've never been able to do that before. At our last office, we were actually told that you can't see these patients for an hour because we don't get paid enough for you to do that. And so, yes. And so that's a big thing. Prior authorizations are another huge thing. When dealing with like TennCare, we were not allowed to treat the patient on the first day. We had to do eval only. So especially our pregnant patients, they would come in debilitating pain, and we would have to assess them and say, I really think I can help you in 2 weeks when your authorization comes back.
And if we have room.
Yeah.
And with our volume too, it was a big struggle to get patients in the door. And then oftentimes when we did see them, it was 30 minutes or less, and that was if the patient was on time, if there wasn't a huge line up front, different things like that. And then they would say, like TennCare especially, would be like, oh, we'll give you 8 visits. Yeah. And then at the end of the 8 visits, we would have to do a reassessment and wait another 2 weeks for them to say, oh, we'll give you 4 more.
I think that's one big thing is like the reassessments and stuff, not charging patients differently for those, not having to do those, doing them every visit as we need to do them.
Assessing.
Not spending our visit time with them doing notes to keep up with things and not having the income that we get from them going towards paperwork.
Yeah.
So it's just we can spend that time. We can write what we need to in a note and then we can, treat them like we want to treat them. So.
And I think that last sentence right there is how, like, what cash base is all about or out of network in general, because, that's something, I mean, obviously if you go into a PT clinic, they're not going to have stepbrothers on the wall and all this kind of stuff. But that's the beauty of it is that, and as far as, testing stuff goes or, squats, whatever equipment we need, insurance can dictate that type of stuff. Yeah. You know what I mean? And that's what I think a lot of patients don't understand is like how much insurance truly drives their treatment and their care, and how a lot of times, therapists and physicians or clinicians are just, hands are tied. There's only so much we can do.
Right. I mean, if they're going to get any profit, then they have to do it that way.
Exactly.
And so it's not necessarily their fault, but, you do sacrifice your level of care when you're being seen for 10 minutes by a public health therapist and then the rest of the time by a tech to run through exercises that you may or may not be doing right. And the thing about public health physical therapy is really those exercises are important to be done right.
For sure.
And it's hard to assess that if you don't really know what you're looking for or without internal.
Or have the training to do so. And that's kind of what we go to school for, is to know that. So that's really interesting. So like kind of run me through just, and this is for everybody else too, like a general session. Like somebody just comes in with, whatever, incontinence or whatever diagnosis y'all want to pick. I just think it's important for people that don't know what pelvic health looks like. That way you can kind of just paint a picture, just whatever y'all think.
We kind of go in stages of treatment. So I guess the first stage, our clinic is a little bit more manually based at the beginning.
Gotcha.
So we're doing like tissue healing, tissue, re-education, things like that at the beginning.
Yep.
And then we might transition a little bit more into like manual and neuromodulation and kind of neuromuscular education and teaching coordination and building those kind of levels of skill. And then we move into maybe more exercise. I think we always do a little bit of manual though, even if we're in exercise.
Yeah.
So I would say, say a patient comes in for an evaluation with us, we do a pretty in-depth subjective intake, looking at urinary health, bowel health, sexual health. Do you have incontinence? Do you have difficulty emptying? Do you have pain? Where do you have pain? Do you have pain head to toe? A lot of people hear pelvic floor and they think that's all we treat. But for us, we are very ortho heavy because what we have been trained and what we truly believe in is the pelvic floor is part of the complex system.
For sure.
And head to toe issues affect it. It is a group of muscles in the very middle of your body. It is the foundation of your core. And so if there is something going on posturally, mechanically, if there's issues in your hips and your spine and your abdominal wall, even all the way up into the neck, down into the feet, your pelvic floor takes the brunt of a lot of that. And so we assess So we do a really thorough intake. And so they spend a lot of their first sessions talking, interviewing. And that's once again in shorter treatment sessions. You don't have time to get to a lot of the root of some of the stuff. And when you have a really thorough interview, it helps you get to what you need to find in terms of treatment much faster.
For sure.
And so that's been a huge, huge difference for us that I've noticed is like, I can identify things I need to look at much quicker, get to them much faster, rehab them much more quickly because we have more time to figure it out. So once we do that thorough intake to really figure out what's going on with the patient, just like any PT would for an orthopedic issue, when your complaints happen, what aggravates, what makes it better, what makes it worse, we then move into assessment. And so our assessment, it varies depending on what the patient comes in for. It typically will sometimes be broken up into, I really feel like I'm assessing. We talk about that constantly. We're assessing every visit.
Every visit.
Sure.
But the major assessment portions are for the first 1 to 4 visits. We talk to patients about 3 phases of care.
Okay.
Phase 1 is investigative. That's when we want to see patients probably once a week in an ideal scenario because we're really trying to figure out what's going on to those first, potentially 4 to 8 visits. We're really looking at all of the different areas contributing to problems. So we do a combination of an assessment of the pelvic floor, an ortho-lumbopelvic assessment, and then based on what we identify mechanically, we start doing a combination of manual therapy and, like Melanie mentioned, coordination retraining. Because the pelvic floor is physiologically attached to the pelvis, spine, the hips, the abdomen, we really work with patients on normalizing any issues in those areas. So for us, it's a lot of postural education, a lot of identifying if you hold tension in like most patients, a lot of people hear pelvic floor and they think, oh, my pelvic floor is weak, I need to do Kegels. And
so you all hear that a lot.
All the time. And more often than not, the problem for a lot of patients is actually they hold tension in their pelvic floor. The pelvic floor is a pressure manager, it's a stabilizer, and it's on if you're against gravity, it's on.
Sure.
And it's also very responsive to the sympathetic nervous system. And so everyone that is stressed, which is literally the whole world.
Yep.
Now,
Especially post-COVID.
Especially
yes.
Yep.
Tend to hold tension in and athletes too.
Yeah. Oh, yeah.
What we find more often than not is athletes are actually very hyperactive in their pelvic floor, and so they really need the opposite of Kegels.
Yeah.
They need down training, they need coordination,
Interesting.
or the pelvic floor might
Makes
be
sense.
tight because of a fault around it. So they correlate hip weakness, hip mobility problems with pelvic floor dysfunction because the pelvic floor is trying to compensate for those issues. Yeah. And so it's all very, very individualized, very specific. So we figure out what's wrong with the pelvic floor, and then we want to figure out why.
Yeah.
Why it's wrong and fix the why, just like any other PT, any other ortho issue.
Yeah.
And a lot of times that can be fairly complex, but by diving into the orthopedic dysfunction and neurological dysfunction, we find a lot of lifestyle stuff. There's a lot of nutritional stuff that goes into pelvic health, just like ortho general wellness, but looking at like hydration levels, sleep, hormone health, different things like that.
Yeah.
Gut health is
patient management, gut mobility.
Yeah. And so what we do is more intensively in the beginning, try to identify all of that stuff, work with patients on resolving the physical components, learning how to manage the other components. And then as patients gain independence, we wean down in frequency. But the ultimate goal of getting patients either completely independent or seeing us as needed very infrequently for issues.
Yeah. And that's what it should be. Because that's the way we practice too. I think we kind of, went over that off camera, a couple weeks ago, but, we try to basically get to the root cause, fix-ish, try to get as much as we can, work in the right direction. And then we do strength training, throughout, past that date, because most time in PT clinics, traditionally, they're going to get discharged and get handed a sheet of paper with 3 sets of 10 and a TheraBand, and they're probably not going to do it. And they're going to get, hurt, re-injured, whatever again. So that's something that we can kind of just, like you said, that independence is going to be huge. So I'm curious as far as, you were talking about all these lifestyle factors. So clearly that's a big deal, right? But if you all didn't have the full hour, how on earth would you get to all that?
Oh, you just can't.
You can't.
It's impossible.
Or you see patients 3 times a week versus once a week and try to just...
Or you see them for months and months and months and months.
Yeah.
And there is a component there. There are a lot of chronic conditions in pelvic health, endometriosis, autoimmune disease, things where it's not a cut and dry rehab. It's not like a ankle sprain where it's like once we retrain and stabilize, we're good to go. And so those patients, and then the other beauty of this system and not having to deal with insurance. Insurance wants you to get rid of people as fast as you can. Yep. And for us, with our chronic patients, if they want to continue to see us once a month or every other month or whatever, we can do it. Yep. You know, they're patient for, and it's really making the decision that's best for the patient. And so for a lot of our complex chronic patients, one of the things I would always struggle with mentally is like, oh my gosh, I don't want to get audited by insurance, and they tell me I've been treating this patient too long and get in trouble, so I'm going to discharge them even though they're still having problems. Yeah. And now it's like we make our goal is to get patients to where they don't need us, but if they do need us, we want to be there for them.
For sure. Yeah, it's awesome.
Kind of like a good blend.
Yeah.
Yeah, and I think in the insurance model, you're always looking at how much progress are you making? Are you meeting this goal? Mm-hmm. But for those type of patients, it's very hard to measure change. I mean, pain, yes, but these are long-standing conditions, and they take a while to heal. So it's nice to not have that pressure and to be able to do what's best.
Yeah. Well, and then that retraining, I mean, that takes time. And you were talking about 3 times a week. Well, that's not 3 hours a week. That probably cumulative will be like an hour-ish, with you all,
right.
with you ladies.
But the time it takes to drive in and go through that whole process versus 1 time a week.
Yeah. Yep.
And I was going to say something too about retraining. So one of our goals is to get, when we're retraining the pelvic floor, for people to be able to transition into any kind of exercise, but to know, like, okay, how do I use my core correctly? How do I use the pelvic floor the right way? And so, we spend a lot of time teaching patients how to understand that, how to feel it, and how to adapt exercises so that they can go into a gym or they can do a home program and then they can, continue with their exercise in a way that's pelvic health safe, which is important to us because, these problems can be lifespan problems.
For sure.
So we want to keep people strong, and we want to do it in a way that's not going to increase their difficulty.
That's what we like to hear. We literally have strength in our name. So, that's right up our alley. So, speaking of going back to the gym, so say that, you've got the issue solved, as close as you can, and then you start transitioning back to the gym and exercise. So, something that we see, and this is not a CrossFit gym, they're not affiliated, so I don't want to, get off, whatever, but get in trouble for saying that. But the big thing I want to think about is the movements that you all see the most issues with. So, the ones that I hear, and again, I'm not told this, it's just kind of seen on Instagram or whatever, is ladies who are deadlifting, peeing on themselves, or doing, jump ropes or any type of jumping type motion, box jumps. What would you all say to those people, aside from coming and seeing you all? You know what I mean?
We would say common doesn't mean normal.
Thank you.
It's probably the biggest thing. We say that so much to my patient. I was like, you should probably tattoo that somewhere on your body.
For real.
Put it on your body.
And I think there's a lot of normalization of these issues because what else do you do? And it's like a society thing, but it's not really a good thing if you're working out so hard you're peeing on yourself.
Yeah.
Something's failing in the system somehow, and you're ignoring it.
Yeah, you're not supposed to be leaking when you're working out.
Not. No, that's a sign that you're not managing your pressure appropriately. Yeah. And once again, that answer to fixing that isn't squeeze your pelvic floor tighter, which is also a lot of people's answers, and it's also figuring out mechanically where that fault is. So it's common, but it's not normal. It is treatable, but it needs to be treated specifically.
Yeah.
And wearing black pants is not an answer.
Yes.
So that is so interesting you say that. I've seen this, and I talk about Instagram all the time because I'm the one that's doing our social media, so I'm always on there. But there was I've actually heard it when I was in that conference in Arizona. So there was a U.S. Women's National, one of their PTs and strength coaches. I think they were 17 and under. And they were saying that, I believe it's in Orlando, their soccer team just switched to black, different color shorts. Because they were saying just how, and again, as a guy, I would never, that would not even enter my mind. Yeah. But when I think about watching SportsCenter and seeing all these just white pants, whatever, that's something I never would have thought about. And then knowing that that people do view that as normal and common, or normal, not common, but that's not something that should happen, and you should just deal with. Yeah. That's something I see so often when I talk to and we talked about this before. But in our intakes, we're going to start really going over pelvic floor. That way we can refer to you all if there is a problem. But that way it's highlighted and that we know about it. Because that's just, and especially coming from guys, talking to females or other males even. Guys don't want to tell other dudes that. You know what I mean? Yeah. But that's something that needs to be talked about. Yeah. So I'm sure that's hard for you all to kind of, I guess unlock that in a patient.
I mean, for us, a lot of times once they're coming to us, they're coming for, but But what we do see a lot that I wish was different is, and there's some research out there about this, is women on average wait 6.5 years from developing symptoms to tell a provider they have an issue.
And this is not talking about the weightlifting world. This
Right,
is talking
yeah,
about,
gym
Any woman.
just women, and so it's probably more with that.
Yeah, and so we see a lot of our patients come and they tell us that their symptoms have been going on for years, but then it gets to the point where it becomes unmanageable.
Yeah.
It gets to the point where they are leaking so badly that they're going through multiple pads a day, that they're scared to leave the house, that they are very cognizant of what clothes they're wearing. They restrict their travel, their exercise, their movement. And because it's like, and so we would really, one of our biggest goals is to get proactive about education and realizing, hey, even a couple drops, if you're jumping, something's going on. And the other thing they find with pelvic floor dysfunction is the pelvic floor is very accommodating. So you may have dysfunction for a long time before you have symptoms. And so generally, even preventative assessments, especially perinatally, like pregnancy, postpartum, you may feel great. But the other thing a lot of women don't think about postpartum, you get your 6-week check to OB and they're like, how you doing? Well, I'm good, I guess. You got 5 minutes with them. And then they're like, all right, well, just get back to whatever you're doing. Great job.
Yeah, so you're clear to lift, you're clear to have sex. That's...
And at 6 weeks, you probably haven't done any of that to know that there's a problem.
Right.
Or you think that it's just part of having a baby.
Yeah.
And so then that's where we also see a lot of injury in the gym is women who have issues and are told they're cleared. So then they go back to doing stuff, and then that's when they start becoming symptomatic, where potentially they could have, gotten assessed preventatively, given some, rehabilitation to work up to that stuff successfully versus after the problem.
Be proactive.
We would really love standard of care to be everyone postpartum gets screened.
That was going to be my next question.
Or treated, even just treated. And in other parts of the world, it's 6 visits postpartum is just built into care. So all of Europe and places in Australia and New Zealand, that's kind of their healthcare system. But no, we don't even think about it. And so we find it when they're lifting in the gym or when they're jumping on the trampoline with their kids or when they have
running.
relapse.
Yeah.
So,
wow.
or pain with intercourse or something like that.
Yeah.
And we say, oh, we could have fixed this.
Yeah. It's just so interesting to me. And again, I'm not a female, so I don't, my brain is not geared that way in a sense of just being able to think about these things as far as what to wear, restricting travel, I just don't, I was number
Knowing
one.
where every bathroom is in the store.
Yeah, no,
every
seriously.
Or timing your errands based on your bathroom break.
Yeah. Well, and then if you got a little one with you, that's another curveball thrown in there.
Yeah.
And that's interesting because you were talking about the pad use before. So something we were told in school was that's not normal. Which is good that was being taught. But looking at or just thinking back at watching TV, whatever, it's portrayed as being so normal though. Almost glamorous. Yeah. Which it makes sense though. Because if it's that common, they're going to make it seem as glamorous as possible. But I think that's just part of the education that you all are doing that I commend you all for. I think that's awesome. That you're getting out there in the community and kind of showing people that this is how it should be, and that shouldn't be the normal.
Well, there's a lot of good spokespeople out there for athletes too, saying that this is not normal.
Mm-hmm.
But, we have a friend who's a gymnast and I asked her, do you ever leak and she's young.
Yeah.
When you land a, move. Oh yeah, all the time we all do. And that's, wait.
It's so just nonchalant about it.
Oh yeah. Isn't that normal?
Yeah.
No, that's not normal.
Yeah.
So why is that happening?
Well, and not just brainstorm, we're big on screening athletes, high school and all the way up. I wonder if that's something you all could do as far as working with high schools.
There's some research out there. I don't remember the exact numbers off the top of my head, but there's a adolescent female athlete stat that a very large percent leak, and it is 80% underreported because they don't want to tell anybody because they're ashamed of it.
Well, they don't know who to tell, probably.
Yeah, and so it's happening, and they're not saying, and so then nobody knows.
Yep.
And so another interesting side note, we could probably talk for hours and hours, but really we're seeing these issues start in childhood for a lot of people. And so our newest therapist that we brought on board, we have added a pediatric pelvic health division.
That's awesome.
And so, I can't tell you the number of times I have a patient where we're talking about urinary problems and they're like, well, it got worse a year or two ago. I'm like, well, when did it start? And they were like, oh, when I was a kid. A lot of adults were when we talk about urinary dysfunction, they were bedwetters, or when they have GI issues, they were chronically constipated as a child.
Yeah.
And so for us, it's like, let's really get back to the source and let's start normalizing education for parents that urinary bowel issues with kiddos aren't normal and that it can bleed into the adult life.
Yeah.
And, fix it when the problem starts. Right now, we see kids, basically the answer for everything's Miralax.
Gosh.
Oh, your kid's constipated, take some Miralax. Oh, your kid's having UTIs, but it's because they're constipated, so take some Miralax.
Well, even educating patients on the importance of milestones, how important some of these milestones are, to make sure their kids are crawling, to make sure their kids are doing tummy time, so that they are hitting the milestones that affect these types of things, their core development, their continence issues, things like that.
Yeah, well, and that's kind of where we're at with Atlas. I was telling Noelle, like, Atlas is gonna be coming next week to do. He's a chunk, so like we got to get the boy crawling. So, but anyway, that's a side note. But no, I mean that's something I think that is huge that you all do. Like, you have such the spectrum. I think that's awesome.
Yeah, that's another common, I would say, you were going back to your original question about like common misconceptions. A lot of people think pelvic health is only for pregnant women or postpartum women, and all it is leakage. But we treat children, we treat men, we treat women, we treat
athletes and non-athletes.
We treat all urinary and bowel issues. We treat pelvic pain. We treat orthopedic pain. I mean, there's a huge spectrum. I mean, if you go on our social media at some point, we did it was 10 slides, the conditions listed. Like, it filled up 10 slides.
Wow.
It's
pretty comprehensive,
it is. And so I would say that's another huge misconception. And then another misconception, especially with a lot of athletes, I think, is geared towards like things like diastasis, prolapse, things like that. And they're like, there's a lot of fear avoidance, and it's like they're scared to move, or they think if they come to physical therapy, we're going to tell them they can't do.
Yeah, be restrictive, which is the norm.
We might tell them that at the beginning, but our goal is to return everyone to the activities that they like to do in the right way.
Yeah.
So, I mean, that really is our goal. We work hard to get people back to what they want to do.
That's so funny you say that, because I literally, before y'all walked in, I made a post about like taking something out briefly, but it's never like, because so often we hear it's like, doc says don't deadlift.
Yeah.
You're freaking kidding me.
Yeah.
Like, and then it's fear mongering, and everybody thinks that it's leads to knee bola and back pain and back surgery, and it's like this whole like undoing of things. So I can kind of see
we have to be careful of our words, because people
sure.
take them and they're pretty sure that it's going to last forever.
Yeah.
So,
But it's treatable, and it's something that can definitely be worked on. So I know we're running low on time, but I'm just curious. Like, when I was in Arizona, they were talking about Red S, and just like kind of the female athlete triad. Can you kind of go over that, like talking about like again, I'm not super well versed in that, but it's
you
like,
educate us on that.
It was just a brief thing that they were talking about, like just athletes like missing periods or something like that.
More like menstrual.
Yes, yeah.
I mean, I would say in terms of like a triad, a lot of times what we see is a combination of musculoskeletal dysfunction, hormonal, and then like a nutritional lifestyle kind of thing.
For sure.
And so for a lot of those patients, if you are missing period, that's another thing. They're missing periods. That's not normal.
Right.
And a lot of it does have to do with, it's like a multifactorial etiology. We see it a lot. And I
think that the Red S is like the missing periods, the bone loss, and the disordered eating.
Yes.
That's what you're talking about.
Yes.
Yeah. So that's
so
more.
wild.
Yeah, that's more. I mean, I guess it's probably in all female athletes, but it's more common among the younger ones, right?
Teenage ones. Yeah, it was that women's national team that was talking about it. So I think they were 17 and under. So like that was something I just thought that was so wild, like hearing that at that age, because again, the common misconception, and I'm a PT, is that it's as we age we start to lose whatever bowel and bladder function or control, and then it turns into that, and that's perceived as normal. So when I heard that 17 and under, I was like, man, we really need to start screening people like everybody. So just when you think you shouldn't ask about it, you should still at least cover that base for sure. I just thought that was interesting.
Yeah. Yeah, and I think that just goes into how PTs, even though we have a musculoskeletal scope, all of that is so tied into general life. And your therapist, your rehab provider, whoever that may be, orthopedic, pelvic, they need to have the time with you to assess all of that. They need to be able to look at your nutrition, your lifestyle, your sleep health, your diet, and they need time to do that.
For
and
sure.
so for us, you know, that's really truly for me, like, and I mean, I don't know for you, Melanie, but like, that's just been the hugest thing for us, just like having the time to figure it out.
Oh yeah, and having that hour is huge.
Yeah, and we refer out a lot. We refer out to, we see a lot of mental health, you know, mind-body connection.
For sure.
We deal with sexual trauma, traumatic history, stress response, chronic anxiety. So we work hand in hand with mental health. We refer out to dietitian a lot. And so just having the ability to do that as well, to just really give the patient what they need. And so if it is something beyond what we can do, we want to help them also figure that out and get them where they need to be.
So kind of quarterback their care is the way I like to think about it. It's like, you know, if there's an issue here, I might not be able to, you know, work with that directly, but I can definitely find somebody who can. And then, you know, we're still working on that issue that you come, you know, to see. So I think that's huge.
Yeah, and I think like our environment is very soothing and calm. And if we're talking about some of the things Noelle was just talking about, like trauma care, you know, to be able to be in and out really quick and to do some of these things that are pretty invasive in a very like medical, fast moving with people all around environment is not very conducive to healing. So that's been another great thing, to be able to take the time to really move through that in a way that's really helpful for the patient.
Be more trauma informed and pick up on things a little easier.
For sure.
Patients are more comfortable sharing. It's also easier for us to be like, hey, there's something going on here.
To notice that. I like it.
Taking the time.
Yeah, that's awesome. I think that's kind of what we've come back to a lot, is just that how our businesses, we definitely take the time to, you know, get to those root causes of when, you know, there's needs some issues. We refer to other people, and that's kind of the network we're trying to build in the Tri-Cities. So
well, and I often think, and I even say it to my patients, like, how do other providers have the time to really get to the bottom of these things? You can't do it in 5 or 15 minutes. You just can't.
No.
There's so many layers and there's so much involved. So it's really a blessing to be able to do that. Yeah. For us and for them.
Yeah. Well, I think that's the fun part of being the clinician, is like that Sherlock Holmes kind of, you know, Enola Holmes type, like, let's dig deep of what this is going on and then try to, you know, peel back those layers. I think that's super cool. So good deal, ladies. You got anything else you want to go over? Pretty good.
Really? Yeah.
Okay. Well, thank you all so much for coming out. We definitely appreciate you. And again, y'all kind of shout out your Instagram. What y'all's handle?
Yeah. It's Empassion Pelvic Health, I think. So for Facebook, I think it's just Empassion Pelvic Health. And then for Instagram, there's an underscore in there somewhere.
Yeah.
I'm like,
Empassion _ Pelvic Health.
Right.
Empassion _ Pelvic Health.
Cool. Good deal. All right, ladies. Thank y'all so much. Appreciate it.